cells. So since that our healthy cells in the body is eating the same food, if we do not take any sugar at all, actually our body will look for other resources, which is actually our fat and muscle, and they will break down it to become the sugar. So end up a patient will get in, be more wasted, okay, and will lose weight further. All right, and we do not restrict sugar unless, for example, a patient that has they have a background of diabetes, or maybe they're on certain steroids, so their sugar level is high, then they may need to restrict the sugar. But otherwise, there's actually no need to totally avoid sugar. And the same goes to rice, for example. Certain patients, maybe they say, oh, rice is carbohydrate, so I'm going to take only 2 tablespoons of rice, and I'm going to take more protein, more veggie, but this is not balanced, okay? Because we know that rice is carbohydrate, so they are providing us with energy, okay? And the calories that we need throughout the day. And regarding the red meat, okay, so because of the recent scares about this from the WHO, okay, so actually red meat, it is still encouraged to take red meat in our diet, okay, about once or twice per week, about the size of a palm size, because red meat actually contains more iron and vitamin B12 as compared to white meat, fish, chicken, turkey, for example. So, and especially for myeloma patients, sometimes the hemoglobin can become quite low, okay, so, and the iron and iron and vitamin B12 is very important to help to increase the hemoglobin level to make new red blood cells. So I would say that there's no need to totally avoid red meat in the diet, but take it in moderation. Once or twice per week, about a palm size, that would be good enough. Okay, okay, thank you.
Any other question?
Madam? My hobby is travel, okay? After my transplant in September, am I allowed for traveling overseas? What are the precautions that I need to take? Is this?
Yeah. So I think again the post-transplant period, the first 100 days is the highest risk, and then we continue to give you prophylactic antibiotics for a total of 6 months. That tells you that that 6 months is perhaps the somewhat higher risk period. But after that, you really should be back to completely normal. So you like to travel, you should just go ahead and travel and make the usual just precaution when you travel. Nowadays, there's a lot of infectious disease all over the world, right? Zika virus, here, this, that. So you got to take some general precaution when you travel too. I mean, carry a mask with you. If it just happens in the plane, there's people sitting next to you is coughing like crazy, you want to put the mask on. So just general precaution, nothing, not to say that you cannot travel at all. But of course, if you're on clinical trial, you better coordinate your travel. That's why I know. You better coordinate your travel with our friendly study coordinators up there. Yeah. So make sure you follow the treatment and all those things. But again, I think that's the beauty. A lot of our clinical trials now, you're being treated once a month, you can still travel, you can still do so many things, even you're on treatment and so on. That's the beauty of myeloma compared to many other cancer patients actually. So in a way, right, the acceptance, is like there are many people worse off than you, even when you talk about patients with cancer, right? I mean, there's a lot other people that is worse off. So there's a lot to be thankful of, even in a bad situation, I guess. Yeah. Sathish, any other? No.
We give vaccination 6 months after transplant, and that's for we give it for pneumococcus and we give it for flu, and this will help to partially help it, but will not completely reduce the risk. That's why wearing a mask when you go on a flight and things will be useful.
Okay.
It's gaining the weight every month is about 1 to 2 kg.
Okay. So this one also quite common, So patients ask, they're worried about their weight gain and so on. So but we need to understand the reason for this weight gain also. Because don't forget, I always ask them, so what is your baseline before you are sick or you're unwell, right? Don't forget, during the cancer process and the treatment and the transplant, patient would have lost quite a lot of weight from the beginning. So when they are recovering, the body needs to catch, is recovering, right? So, unless the guy at baseline when the patient is well is like 60 kg and now you're going up to 70 kg, then something is wrong. I mean, we need to look at the diet. Whether is it because the patient is on steroids, is eating too much, and the steroids is contributing to the weight gain, or in fact the patient is just catching up to the baseline weight. So if it's just catching up, then there's nothing wrong. Just carry on. But it's important to watch the diet a bit too and not go overboard with because sometimes you'll find that your concern is a bit different. So you say previously it's like we lost a lot of weight, I want to eat more. So then you go on this really eating a lot to build yourself back, and then you can tip the other way. So I think sometimes it's important to just monitor and be sensible about what the weight is doing versus when you are well. Yeah. Sathish, anything to add to that?
I think increasing weight is good for most people.
Yeah.
Not for everybody.
Yeah. No. Anything else there about the weight concern?
Just maybe a little bit of addition is that, for example, previously we do encourage like a smaller but frequent meals, small snacks in between meal time. But say after the recovery, during the recovery phase, when you're eating well, able to finish one share, you can keep to your 3 main meals, and maybe you can decrease the snack and just maintain a healthy body weight. Yeah.
Okay, this is talking about bone marrow transplant, stem cell transplant. Okay, for what I read, I'll be careful, I read a lot. Also, I also see some of them never do bone marrow transplant. We actually live for 2 years. Then some people do bone marrow transplant after 1 year relapse. So is there a immediate need to do a bone marrow transplant? That's the question I'm asking. Because if I can prolong for 2 years, in 2 years later, of course I can harvest my stem cell. I don't know how long can we keep. And maybe by 2 years time, a better system that can kill most of the cell, the best cell in the bone marrow. That's I read in the Cancer Connect. I mean, the US has some system that almost kill everything. But that's what they say. I mean, they claim to be. Sure. So is there a need that we spend 6 months of good quality time to do the bone marrow transplant and you relapse in 2 years? Right? That's what I'm trying to say. Because if we're talking about with survival rate of 5 years, 6 months is quite a lot.
So I'm sure Sathish will have comments on this as well, but I would just say that this again is a very common question, right? And it should be addressed properly. So I would just say this, that first question is whether you need a transplant or not, okay? And the answer there is a definite yes. For patients who are younger or who are fit enough to get a transplant, studies throughout the history of myeloma treatment, many studies, so we're talking about 10 over studies, including very recent studies in this current era where we use these very active drugs like Velcade and so on, have shown that patients who have transplant versus those that don't have transplant but just continue to be treated with these new treatment do better. They survive longer and they have better response, they have deeper response. So there's no doubt that patients who qualify and can have transplant, they should have a transplant because it actually benefit them. 2 years of additional survival, 3 years of, as Dr. Sathish just now flashed one slide, shows that the transplant patients, 97 months of is significant, So that settle that issue, whether I need transplant or not. Yes, you need transplant. But the question that comes next is that, do I need to do transplant now? Can I do transplant later? Okay, and that has been asked by many patients as well, So that is a not so straightforward question because there are not many studies that looked at, well, in fact, some of these newer studies that look at whether to do transplant versus no transplant, these patients actually do get transplant later when their disease come back. And these studies tells us that actually when you do transplant later, when the disease come back, the outcome is not as good, okay? There's other reasons as well. When you do the transplant or you try to do the transplant when the disease come back, you cannot predict when the disease come back how bad it's going to affect you. You know, some of these patients, when the disease come back, they have kidney failure, straight away transplant may be not possible already. So there's a fraction of these patients that actually lose the chance of doing the transplant when their disease come back. Whereas at the beginning, when we are planning the transplant, usually that is the stage where the patient is the fittest, the disease is best controlled, they're most ready to go for the transplant, you know, physically and in terms of disease. So that's the best time for them to do the transplant. But when they want to do the transplant with disease come back, some of them, the conditions may not be good. Some of them, you know, they can't even do the transplant because of some problems that's happening. And so that's the reason why we suggest that the patients have the transplant right at the beginning. And if you think about it, if you're prepared to undergo the transplant, whether now or later, might as well just get it out of the way. Then after that, you can continue to do the things that you like to do. Whereas if you don't do the transplant, you actually need to go on to have more treatment. You cannot stop your treatment just like that. You know, you need to continue to have more treatment, and you probably end up having longer period of time on treatment than without treatment. So, you know, there really is not very good reason not to do the transplant up front. But we can store the stem cells for a long time, you know, so that is not a reason for not able to do the transplant later. The stem cells can be kept for years, you know, so it's not an issue. But I think there's very few reasons not to do the transplant at the beginning, really. And then the third thing you ask is, do transplant also relapse? Don't do transplant also, you know, sometimes relapse? But this goes back to the point that we cannot, every patient is different. So we cannot predict, say, patient A, if you do the transplant, you are not going to relapse early. You know, but what we can recommend is, we know for most of the patient, the transplant will help. Clearly, there are some patients that the transplant won't help. But it's not because you do the transplant that the disease come back early. The disease is just a bad disease. It's going to come back anyway, right? So what we do is we recommend the best treatment that we know of for all the patients. And by doing that, it will benefit most of the patient. But clearly, there is going to be some patients that, despite doing that, because they have bad disease, the disease will just come back. So, you know, I have had patients who say, you do the transplant, then 3 months later or 6 months later, you tell me I'm relapsing again, you know, what are you doing? But that's the nature, you know, we cannot predict at the beginning all the patients that's going to do well or not do well. Some patients have, based on our risk stratification, have good risk disease. You know, by all intents and purposes, they are supposed to be doing well. But they didn't respond well to the transplant. After that, they relapse early. That tells us that this guy has bad disease that we cannot predict up front. So I think this is my answer to your question. Hopefully it kind of addresses your question. Satish, you have things to add?
Just an extra comment. At least on two fronts, early transplant is better. One is that quality of life. And the second is cost of care. Because these two, is very clearly shown that if you do an early transplant, you know, there's clearly superiority. The question that you're asking is, can we avoid transplant in any patient, is a bit more exploratory. Right now, you know, we are identifying ways to see patients who may not need transplant up front, but we are not in a position to recommend that to all patients. So there may be a small subset of patients who may not need transplant up front because their myeloma is so well sensitive that a transplant might be an overkill. But right now, we don't have any ways of predicting that population. In fact, we are planning to open a clinical study later in part of this year using the same drug. And what we are theorizing is that in people with low-risk myeloma, that is just opposite to high risk, if they achieve a very good response after 8 cycles of treatment, then, and by using the special techniques that we mentioned where we can look for cancer cells in very low number, if such tests also turn negative, we don't do transplant. But even that is a clinical trial, and we don't know whether they will, you know, whether they will relapse early or not. And such patients, we are collecting stem cell early and keep storing them, because if they relapse, then we can use them. But that is a clinical trial, it's not recommendations standard. For most patients outside that, we would say, you know, do transplant. A good treatment is good when it used the right time, you know, not at the wrong time. When you relapse again, more morbidity, more problems, you know, more cancer to treat again. You're not even sure whether you can get to transplant. So it's better when you're first time, when the cancer is more sensitive to drugs, that you go in with all effective treatments. Okay, that's different.
So you see what happens, the cancer or relapse will be at least 1-2 years. So I'm considered if I can delay for 1-2 years.
Okay, well, that's a different story altogether. Okay, that trumps everything. How's your lung cancer? It's been cleared now, is it?
Yeah, it's not a cure of the cancer cell.
Okay.
Means this 2 times do the CT scan.
Okay.
It's cured.
Okay.
But because it's stage 3A male, the statistic, the chances of return will be very high in these 2 years.
Okay, that's a different story, and I think that is very personal. Actually, I think that will need a long discussion. But that's a different story, and I think that's perfectly reasonable to think like that. Yeah.
Yes, I have a question. Right now, I'm taking care of my mother, whose myeloma is going through a relapse, and it's coming back really fast. And my question is is there any other available indicators or tests here in Singapore to determine which treatment to use? Because at this point, she's really weak, and then for her to be tried on different treatments, we are wasting a lot of time. That's what we see, because she's getting weaker and weaker. And that is number one. And number two, also, as she is getting treatments, and some works and some doesn't, how long has the patient, how long do we have to wait until we have to see that treatment works or not, or how long do we have to wait?
Okay.
Yeah.
So can I ask you about a bit of information about your mother's previous treatment and whether she had transplant and how fast after the treatment she relapsed?
Okay, she has never had a transplant, and she has only given Velcade, but not a full, just a few times. But
how many times?
About 4 shots.
4 shots. That's 1 month.
Yeah, that's one. And then she is 64, and but that brings her into ICU for 6 months because her body just got infected with a lot of things. And then she came back out of the coma, and then she had only given Revlimid for 10 months, and she could come back home, and she could have a good life for a good 10 months.
After 10 months of Revlimid?
No, during just
Okay.
So after the coma, she had a healthy life. I mean, a fairly healthy life for 10 months until the cancer, the myeloma relapse.
Okay.
And then when it relapsed, it just week after week it went shooting up really
Okay.
fast. And now she's warded here, and we're just asking what kind of indicators, because it's only just the protein counts, and it seems that we are just trying different kinds of all of the list of the medicine. We're just trying things out, and some work, some doesn't. And she's just suffering from all kinds of side effects. So I'm asking, is there any other indicators that we can see? And how long should we go through one treatment until we say, this doesn't work or this works? Yeah.
So the answer to the issue here is that your mother relapsed towards the end of the 10 months of lenalidomide. Is that correct? Okay. And she only got 1 month of Velcade, right? Yes. So I think the important thing is that when people relapse from a treatment, we try to give a drug that is different to their most recently exposed drug. And this is because we believe that they are more likely to be resistant to the previous, previous treatment. So, that's one way of trying to extract more response from a patient. So I think that, if this were happening to a patient that I know of, I would probably recommend, going to a Velcade kind of treatment rather than lenalidomide, because it's straight relapse after lenalidomide. And in terms of, I might even add in some chemotherapy to give a faster response, because the median time to response with Velcade is not a long time. But even that may not be enough for some patients. Actually, Velcade works within weeks of starting treatment. But if you have a lot of disease, sometimes adding chemotherapy and making it more like a guaranteed tumor kill, just to increase the effectiveness of the treatment, can be done. But right now, other than looking at what treatment they've had before and trying to cycle the drugs, it's a bit hard to have a prediction system to say that, okay, this drug is likely to work, because none of the studies that have been done so far have been able to say, okay, your cancer is, so we have not reached the personalized cancer care in myeloma yet. Although it's more or less there in lung cancer, for example, we don't have that in myeloma. So right now, the best guess we have is cycling drugs and see the drug they have not had recently. But the good thing is that we can add in chemo, and we can also look at the response to treatment. Light chains can be monitored in 2 weeks' time and things like that. So we can monitor light chains 2 to 3 3 weeks duration. M-band might take a longer time to go down because their half-life is longer. So that's the way we normally do it. In terms of predicting treatment, we are not there yet. So that's my opinion.
I think I saw you, right? Yeah. So it's the same. I think for your mom, Velcade treatment should be tried. The ICU admission with the last treatment, I think, is not related to Velcade. At that stage, your mom just had the disease. It's very common for newly diagnosed patients to have severe infection, and it's probably that. And in fact, if I remember correctly, your mom had a very good response with the Velcade. In fact, but it was truncated because they decided not to give any more because they thought it was the problem. So I think you need to, at this stage, you need an active treatment regimen. Velcade is very active, particularly in this case where the patient hasn't really seen a lot of Velcade. And measuring something like the free light chain, which has a much more shorter half-life, so it responds faster, you can have an early indication whether the drug is going to be working or not. But because your mom at the moment, I think, is also a bit frail with other complication, right? I would be a bit cautious about adding too much drugs to the Velcade, because then it may cause more side effects on the blood count and so on, which will make it difficult. So in fact, I cannot remember exactly, but I would suggest using Velcade and steroids first. As she stabilizes, you can add in the cyclophosphamide or additional thing to that regimen to make it better. Because I think Velcade will probably have the less side effect, fastest work rate, and it's probably your best chance. And sometimes we may have to bite the bullet, because if your mom, say, currently has infection, has some low blood count, and the doctor is a bit worried about starting treatment, as long as the infection is already under control with a few days of antibiotics, and the patient is quite stable, I think you have to start the treatment and support with the blood transfusion and so on. Because the longer you wait, the myeloma will just go high, then you won't have a window to start your treatment. So, you may have to take that that kind of move, especially in this aggressive relapse setting. You have to... Oh, okay, great. Thanks.
Which one is more effective between low dose dexamethasone and high dose dexamethasone?
Okay, so when you say low dose, how low?
Below 20 milligrams.
Below 20 milligrams per week. Okay. I mean, I would just say that last time the way we used to give dexamethasone is 4 days of 40 milligrams, and then 4 days of rest, and then 4 days of 40 milligrams, 4 days of rest, and then 4 days of 40 milligrams. Meaning that in 1 month, they are having 12 days of 40 milligrams dexamethasone. That is what we call by high dose dexamethasone. The current way that we're giving of 40 milligrams once a week is already the low dose dexamethasone, okay? So studies have shown that if you give the high dose versus the low dose dexamethasone, there's much less side effects with the low dose. The high dose, a lot of side effects, and there's no difference in the effectiveness or outcome. So that's why now we all use 40 milligrams of dexamethasone once a week. But we also know that for the older patient, patients above 75, say for example, 40 milligrams is very high for them. They have a lot of side effects. So there is also guidance that for more frail patient, older patient, we reduce that down to 20 milligrams once a week, okay? But if you're talking about even lower than that, then that is not recommended. But sometimes we do that because when patients get 20 milligrams, still have side effects, then we will slowly reduce the dose. But we will not start straight away by giving just 12 milligrams. We will start with 40 or 20 and then slowly reduce down. Because, if you give a drug that is not effective, might as well don't give the drug, right? I mean, so you got to give an effective dose and a good enough dose. And then if it's producing side effects, then we slowly reduce from there rather than the other way round very often, right? because you're wasting time. If you're giving a ineffective dose, the patients feel very well, but are we doing anything for the disease, right? So it's a balance. It's always a balance. And if you give low and work up, you may waste a lot of time because it's always a battle between the drug effect and the tumor effect. If the tumor is growing faster than the drug is working, then the disease is progressing, right? So that's the principle of treatment.
For the long term, can DEXA cause osteoporosis?
So the recommendation is that we treat you for the first 2 years with weekly and monthly bone injections, as long as the myeloma treatment is active, or for 2 years, minimum 2 years from diagnosis. And after that, we need to cut down the frequency, provided you're not on treatment for myeloma. So that should partially take care of osteoporosis. And also, you need to take calcium and vitamin D3 as part of your treatment to strengthen the bones. So it's a balance of, most people would not take DEXA for 2 years. The treatment is mostly a finite period, like 6 to 8 months, and then transplant. Most of the maintenance do not include steroids. So we don't expect you to be on steroids for a long time. So, the risk of osteoporosis has to be offset by, the risk of myeloma not being treated. So it's a risk of unknown in the future versus a certain risk of myeloma not being treated adequately. So that's why you need to compare and see which is good for you and what works better for you. So sometimes